So we're going to finish out this morning talking about gastroesophageal cancer. I see some people in the audience have been asking various AI tools what the best papers of the years are. It's kind of interesting. Looks like they kind of line up with what ChatGPT said. Great to see the faculty here today, as well as Dr. Chotsky. So we are going to talk about gastroesophageal cancers. We have Dr. Sam Klempner from the Massachusetts General Hospital and Dr. Yelena Janjigian from the Memorial Sloan Kettering Cancer Center, and from Trinity, Florida, and the Florida Cancer Specialist, Dr. Mamta Chotsky. So, Yelena, we've been asking people with each module what do they think the most important paper of the year was in their area and where they see things heading in general. I asked ChatGPT that question. I'll tell you the answer in a second, but I'm curious what your answer is in terms of some of the biggest papers over the past year from your point of view, Yelena.
The two biggest papers, I think in chronological order, since it hasn't been a full year yet, and we presented this at ASCO, is the Matterhorn study in the perioperative setting, and the most recent in January at ASCO GI, the Horizon GA study. So the field is moving to perioperative therapy with Matterhorn, and we'll touch on it briefly. But the HER2 paradigm is shifting, and these patients live longer and better with this disease.
Yeah, of course, Sam, that Horizon study looked at the bispecific zanidatamab, which is actually approved in biliary cancer. And you wonder whether it's going to be, we'll talk about it today, maybe it's going to become part of the first-line therapy now with HER2-positive disease. Anything else you want to say about what's going on in the field in general, where you see things heading?
Yeah, I think we saw Destiny Gastric 04, which kind of solidified the HER2 ADC against our standard second-line therapy. So that was a nice verification or validation of what we're already doing. And then, of course, there is Claudin drugs. There's a lot of interest in this and combination strategies. I think also plucking out biomarker-selected groups, MSI high patients in the non-metastatic setting. We may be even getting to sort of what place where we can get to non-operative management in very selected people.
Mamta, any initial questions you want to bring up here? Again, all these cancers, more and more, we're doing biomarker studies. Any questions about when to do biomarkers, how to do it, what to look for?
So in my practice, I like to do biomarkers ahead of time at the time of the diagnosis. I think that is becoming kind of a standard of care for all the patients. The questions I have when you mentioned about the MSI high patients in a localized cancer, we have several IOs options now available, and as a community oncologist, I would like to know, how do you choose and which one is your go-to IO for? At least we have 4 that I can choose from the NCCN guidelines.
Yelena, of course, we're going to have a program here, a module here on colorectal cancer, and of course the work that was done at your place looking at neoadjuvant IO and MSI rectal cancer is really something, that was probably the paper of the year in colon cancer. What about neoadjuvant IO in gastroesophageal MSI high disease?
Exactly. So, of course, the dostarlimab paper, the second paper in pan-tumor came out, and we know that monotherapy with anti-PD-1 is insufficient to induce complete responses in majority of our patients. In fact, in that study, the dostarlimab study in gastroesophageal cancer, only about 40% of patients reached complete response. And at AACR, we had a whole plenary session covering this topic. And to boil it down simply, you have to choose between dual immune checkpoint blockade or chemoimmunotherapy. And of course, Matterhorn is the standard, but Nivo, Ipi, or Durva-Tremi with a single dose of Tremi, the same way that we use in HCC, shows great complete response rate, not perfect. So you have to monitor carefully if you're going to do non-operative management. But those are both good options. And the way that we typically decide and the paradigm is in the clinic, you start potentially with dual immune checkpoint blockade due to an early assessment of response. And if you are not seeing the response that you're hoping for clinically or radiographically, you can pivot to chemoimmunotherapy with anti-PD-1 plus FLOT.
So again, Sam, any thoughts about immunotherapy in MSI high gastroesophageal cancers? Are there differences in how sensitive tumors, whether it's in the rectum or stomach or prostate, et cetera, in terms of how effective IOs are in MSI high disease?
Yeah, it's a great question. I think in colorectal we have higher rates of germline predisposition syndromes associated with MSI. So the MSI is truly clonal, where in gastric and esophageal cancers, MSI biology is usually sporadic, and therefore it's not always truly clonal. And there's been some actually very nice papers. If you look at stomach cancers, there is regional heterogeneity in the MSI. So there'll be a region that's MSI high and a region that's MSS, and that is a result of sporadic MMR generation.
Yeah, we were talking. We were mentioning we were in Puerto Rico for the SGO meetings, and there they were talking about neoadjuvant for MSI high endometrial cancer. Mm-hmm. They're just starting to look at it. Are they going to see the same thing with rectal cancer? But really interesting. All right, Sam, let's talk about PD-1 and Claudin 18.2.
Will do. Well, we're going to talk about people who can't really eat right before we have lunch. Here are my disclosures. So I was asked to talk about some perioperative updates, picking out these subgroups that Neil just touched on, a little bit about the frontline checkpoint landscape, and then some Claudin therapies. So as Yelena mentioned, it used to be a debate of carbotaxol radiation, perioperative chemotherapy, etc. But now, after Matterhorn, which I agree is probably one of the papers of the year, it's really become much more simple clinically for us. If a patient is operable, this is the preferred approach. This is why we saw this data at ESMO, and this data is soon to be published. But why did we change practice? Because we have therapies that are now improving event-free survival, which we saw and is published, and now overall survival. So I'm a simple person. I think we can now tell people that the overall survival at 2 years, 3/4 of patients are alive, a little more than 2/3 at 3 years, and certainly we'll wait to see long-term follow-up from Matterhorn, which will be important to sort of define that 5-year cure rate, which is what we want to be able to tell patients. I want to highlight a couple things that was presented as part of this presentation, which is the prognostic impact of pathologic response. We've talked a lot about neoadjuvant therapies, and neoadjuvant therapies are essentially measured at the time of surgery, and you see that if you have a complete response, that top line is plateauing around the mid-90s%. So these patients do very, very well. And of course, the durvalumab improves versus the placebo. Same thing for major pathologic response. But as you have lesser of a pathologic response, the prognosis is just worse. That is true of primary tumor, and that is true of looking at the nodes as a sort of surrogate for the sensitivity to the systemic chemotherapy and immunotherapy. Again, node-positive patients, you see that green bar, the green curve. Compare that to the green on the other side in the node-negative. You see the difference between being node-positive at the time of surgery and node-negative is substantial. And a lot of this is just biology. This is a very heterogeneous tumor group, but it's still a very prognostic impact. And I'll come back to that when I talk a little bit about pulling out neoadjuvant groups. I grew up in the 80s and 90s, and I remember Waterboy and this "you can do it" meme, but I want to remind people that a lot of the questions about FLOT clinically is like, can we really give this to patients? And in this really big global phase 3 trial, this is a busy slide, but I put it here for reference since you have the slides. You can see that almost everybody was able to get through the neoadjuvant component. More than 90% of patients are getting all their neoadjuvant therapy. And even in the adjuvant component, it's about 3/4 of people that were able to start adjuvant FLOT. So we can do this, and we can do it in a deployable manner. And I'll be interested to hear, your take on how your perception of FLOT and durvalumab has been.
Before we go on, let's get right into it. Actually, before we go to Mamta with her questions, coming back to you, Yelena, can you just specifically talk about the situation when you would use Matterhorn, exactly what the situation would be, and what about in the older patient, with compromised performance status?
Right. So I think the first decision is whether or not surgery is an option for this patient. So if they're medically inoperable or do not wish to have surgery, that's very different. But if they're fit for surgery, I think, and if they're borderline, for example, it's an octogenarian patient who really, wants to focus on maximum chance of local control and then not worry so much for cancer recurrence. And if it's a resectable tumor, then I would go straight to surgery. Every other aspect of it, I think combination of chemoimmunotherapy would be a good option, followed by surgery or chemoradiation. So we now have data, and you will see it at ASCO and published, coming out of Asia, that actually a doublet regimen, like FOLFOX or SOX type regimen with anti-PD-1 therapy also improves survival. So I think it'll give those clinicians who don't feel comfortable doing FLOT an out potentially and justification. But I have not considered radiating a patient in whom I'm planning to do surgery. You do not need two forms of local disease control. So it's either or. So we would only do radiation in a patient who, for whatever reason, does not want to have surgery or is not surgical, and you did not achieve complete response with chemoimmunotherapy.
Mamta, any questions? Have you actually used the Matterhorn strategy?
Yes, I have patients on it already, have started using it. Actually, as a matter of fact, I have a patient right now who has also HIV on a hard regimen and is controlled, so we are cautiously doing it, but so far he has been tolerating it, and he just actually completed 4th cycle.
Any comments, Sam?
Well, one, I think we've learned over the years checkpoint inhibitors should not be restricted from HIV-positive patients, especially those with good control. No, I agree with Yelena's comments. That's basically what we do. And I'm pretty quick to drop the doses of FLOT. Like even if someone is a little more frail, like docetaxel 35 instead of 50 and oxali 60, 65 with the 5-FU, like people actually do pretty well.
Any Yelena, you mentioned sort of a non-Matterhorn strategy. So which IO and which chemo?
We typically use durvalumab and FLOT, and then even just try to get 1 or 2 doses of triplet in, because it does make a big difference in terms of complete response rate. And as Sam mentioned, I rarely use full dose FLOT in your average 70-year-old patient. We dose reduce from the beginning. If you were to pivot to doublet, I would just use flow, so just drop the dose, because the 24-hour infusion of 5-FU is quite easy. And again, I think it's the easiest regimen to get approved. Occasionally, we've used FOLFOX/nivo, and again, in a patient where I'm thinking it's going to be probably 6 to 8 months of therapy, and so FLOT will be too toxic.
So Durva flow. Mm-hmm. Interesting. Okay, Sam, let's keep going.
Perfect. So this is just a reminder that although we manage these patients all similarly clinically, they're actually quite different molecularly. And so obviously this is the clinical side, and the sort of the scientific side on the other is that there's a lot of heterogeneity in gastric and esophageal cancers, almost unique among cancers and particularly in the GI space as well. So if we could pluck out these patients and say, hey, these people share enough molecular features that we can lump them together and we have a good drug, you could see, logically that would make a lot of sense. And this is exactly what MSI high is doing in the non-metastatic space. So as was alluded to with doublet and PCR rates, this is a nice recent meta-analysis basically asking questions about how well does neoadjuvant therapy do in microsatellite high GI cancers. This is particularly to the upper GI is what I selected for slides. But you can see, and if you know these regimens, we're happy to go through, but as you move down, it's the prevalence of path CR. You see the neonapiga and infinity. Can I point to them? How do I go back?
I don't think so.
I can't point to them very easily, but those are the doublet regimens, and you see the path CR rate is in the 60% range. So this is telling us we have very, very biologically active doublets. The other question that comes up a lot is how long to give neoadjuvant immunotherapy. So here, what the investigators did is they asked the question of if you did it for more than 3 months or less than 3 months. And again, this is not a formal comparison across these trials, but if you look at the greater than 3 months, you see as you move down the path CR rate tends to improve with a little bit longer duration of neoadjuvant immunotherapy, here stratified by 3 months, because that's what most of the trials have done. So in some of these patients, you may be able to make an argument, especially if you're thinking down the non-operative path, that a little bit longer neoadjuvant immunotherapy may not be a bad thing. This is exactly what Yelena alluded to in a minute. This is data that was just presented last week at AACR, so hot off the press, and thankfully knew the investigator to give me these slides. But essentially, they had 2 arms of this trial, and this is the STRIDE regimen, so 1 dose of durva-tremi and then durva. And you see that the cohort 2, which is if you had a complete clinical response, so radiographic and endoscopic with negative biopsies, you were gone down a non-operative management pathway. And in the bar graph, you can see that most of the patients achieved a complete clinical response, and the primary endpoint, which was complete clinical response at 2 years, was 70%. So these are patients who had no surgery and were microsatellite high, able to be spared a large operation. And you see the survival data is very, very good, 95 to 100%. And the gastrectomy-free survival, because there was 1 or 2 patients that needed to be salvaged with an operation, is also very high. So this is really laying the foundation, and I think HER2 will be the next biomarker to follow in this path. But we're getting to a place where we can actually start to think about selecting people for non-surgical approaches and still have good outcomes. I'm going to pivot a little bit towards the metastatic setting, and I'm not going to spend too much time here because this is data that's been around for a while, but these are 2 newer papers. One is a paper that just recently came out from Yelena, and the other is Keynote 859, which has not had long-term published data, but this is the ASCO presentation. And really all I'm showing you here is that these are here to stay. We now have long-term data and 5-year survival rates. You can see there in the 12% for the all randomized and then the 13% for all PD-L1 positive. It looks very, very similar for both of these trials. Only to highlight that long-term benefit is really not something we see very much with chemotherapy alone. You can see the blue curves, but with the addition of immunotherapy, some of those people are way out on the tail, and it's nice to see data about who they are and how long they're living. I'm going to talk a little bit about Claudin because I was asked to. This is the benchmark for Claudin, and this is important. This is the pooled data from Spotlight and GLOW, which were the zolbetuximab plus chemo trials, and you can see a similar phenomenon. There is a tail here, and this is in a biomarker-selected population with a biomarker-directed therapy. Most of our trials will produce a tail like this. And so here we only have data out to 4 years, but 4-year survival rate also looks quite similar to checkpoint inhibitors, which asks you the question, what will it look like if we combine everything together, which I'll show you the data for in a second. This is what ChatGPT thinks about going from zolbetuximab and GLOW and Spotlight to Illustro. I don't know why it chose those images, but that's what it did. The mechanism over here is really leveraging sort of the 3 approaches to treating this cancer. We have cytotoxic chemotherapy, 5-FU and platinum. It's not going anywhere. We have biologically directed antibodies, in this case a naked antibody, zolbetuximab, and then we have T-cell checkpoints like nivolumab and pembrolizumab and others, and all of them have somewhat independent but also merging mechanisms of action. And so that is the rationale to think about combining these, which was exactly what was done in the Illustro trial. So this trial is now published, but it is essentially a representative frontline population of gastric and GE junction patients who are Claudin positive. Most of the patients are Claudin greater than 75, but they did allow a lower intermediate Claudin threshold onto this trial, but you can see it's only 14% of the trial population because Claudin distribution is relatively bimodal. Most of the patients are positive at a high level, and then there's a subgroup at the other end which are not captured in this trial. These are the outcomes, and so you can see the progression-free survival. So this is not overall survival. This is progression-free survival in this cohort, and take all small trials with the caveat, is about 15 months. And if you really select the patients, so the PD-L1 positive, which is CPS 1, and the claudin high, the standard zolbetuximab definition, you see we're now at a 2-year median PFS, and we'll see if all of this holds up in larger phase 3 trials. The safety is the safety of these drugs. Their safety profiles are well described and well known. I will highlight one thing here, is that the rates of nausea grade 3 in the bottom right were 0. And it was about 20%, 16-20% in Spotlight and Glow. And I think all of that tells us is that it's not like nivolumab reduces the nausea of zolbetuximab. It's just that we've gotten better at managing these patients. And you guys are all managing these patients, and we're learning from each other about what are the optimal antiemetic strategies. But with proper management, within just a couple years of Spotlight and Glow to Illustra, we've gone from almost 20% to 0 in the grade 3 nausea. So we're just getting better at managing it. These are some general management guidelines, which I won't belabor, but it's consensus, and so maybe I'll stop there for some Claudin questions.
Yes, and also some questions we got from what we were talking about before. Incidentally, I'm glad I'm not the only one asking ChatGPT to do cool graphics. Last week we did a program on small cell cancer, and I asked ChatGPT to come up with an image, like a metaphor for small cell, and it showed a wildfire in dry tinder, which the faculty thought was pretty appropriate. So one question about this intriguing tail on the curve, Yelena. What are you telling your patients who are getting IOs in the first line, or now maybe even Claudin, in terms of the possibility that they may get out 3 to 5 years and be doing well?
When the patient comes in and they're newly diagnosed in first-line setting, there's so much uncertainty, and it's difficult to live through it. And what I tell them is that there is a chance that you will be alive and well. And that just simple statement, you could feel them relax, and they take a deep breath and they start listening. So I think it's an important piece of hope that we can give our patients. And yes, the responses are heterogeneous, and we don't know for a fact who will be those patients on the tail end of the curve. But the fact that that end does exist, and it continues. And I tell them we just updated our survival from our 5-year, 6-year cuts from various phase 3s. And this is a phase 3 setting, meaning that these patients are treated all over the world. And when you're in a tertiary cancer center getting care from a specialist with special nursing care, et cetera, your chances are even better. And that goes a long way for them.
Yeah, I mean, again, in small cell, it used to be extensive stage disease. Nobody survived 5 years. Now they have 10 or 15%. Big difference in how patients see that. So a bunch of other related questions. We'll just sort of fly through a bunch of these, starting with you, Sam. Do you use post-op durvalumab if the patient has a path CR?
Yeah, great question. I think short answer is yes. We don't have data to say that you can forego the adjuvant therapy. I think it's reassuring to know that that patient is quite likely to do well. And maybe I would have a little bit more comfort in dose reductions for toxicities, but no, I'm not foregoing the adjuvant component completely in all patients.
Just a follow-up, Sam. How do you approach a patient who has a CR to durvalumab but then doesn't want to go to surgery?
Yeah, so it's definitely painting outside the lines, but we would for sure scope those people and biopsy them and do everything we can. Often that may be a place where if you had a preoperative or early phase ctDNA test, that might help you even increase the confidence. It's a risk for sure, and the sensitivity of surveillance is far from perfect, so that person has to very clearly understand what they're signing up for, and I'd say it's pretty uncommon that we do that. We sometimes will consider consolidation at that point, but not too common of a scenario.
Yelena, PD-L1 negative adenocarcinoma of the distal esophagus with node positivity. Question, still Matterhorn or consider pre-op RT with chemo?
I would read the fine print on the pathology and have them retest it, make sure they're doing it with TAP criteria. In my experience, when this was a PD-L1 negative sample, many times there's not enough stroma in the sample and it's fully replaced by tumor. Every PD-L1 score is negotiable when you speak to them. Typically, I would still do FLAD-Durva. Chemoradiation is just not going to cure your patient. If you don't want to do that, FLAD-Durva, you could do FLAD alone or take them to surgery.
Another question about HER2-positive disease, Yelena. Would you consider adding anti-HER therapy to periop durva, or is it being done in a trial?
Yes, stay tuned. We have a slide on that, and the short answer is absolutely. The rate of complete response is great with that regimen. And to your earlier point about non-operative management, we encourage patients to do it in the setting of a clinical trial. And now, if you have a clinical trial and non-operative management is not in the informed consent, the patients ask you why. So the modern studies do have that.
So Mamta, Sam seemed pretty optimistic about dealing with GI toxicity from zolbetuximab. When I started to ask people when it first came out, I was hearing kind of not great stories. What's your experience? Any questions about it?
There are side effects. We have noticed it for sure. Nausea and vomiting is also part of it. With all the novel and newer agents, I think we have been able to manage it, and the most of the time we get the patients back to the office for hydrations and antiemetics with a close monitoring and support. I think we have been able to manage the toxicity.
Have you tried slowing the infusion down? Do you find that effective, Sam?
Yeah, so first, there's still plenty of grade 1 and 2 nausea with the drug. Grade 3 is really bad nausea and vomiting. So it's a well-described thing. I mean, honestly, we heavily medicate the patients. Ativan, Benadryl, steroids, NK1 and HT3. And it's a very long day because it's 4 hours on the first Zolbe day and then 4 hours for chemo. So a little bit of Benadryl and Ativan and a nice rest is not the worst thing. But we do sometimes slow the infusion, and there's a debate about whether you need the loading dose because most of the nausea is in the first cycle. So there is an ongoing randomized trial about loading dose versus no loading dose. And I actually suspect that we probably may move away from the loading dose.
So let's hear about Lucerna. One of the questions that came out immediately when these trials came out was, what do you do if they're PD-1 positive and Claudin 18.2? Of course, oncologists says, let's go do both. What do we get?
Yeah, I mean, now we have Illustro phase 2 data to say what you get with 2, but this is the phase 3 trial, which has accrued quite well and will read out, and we'll know the answer if Claudin, PD-1, and chemo is better than PD-1 and chemo. But I'll wrap up quickly with a couple comments on the newer drugs, which are the mainly ADCs and BiTEs. We heard a lot about bispecifics in the last session, so I won't go through the graphic. And ADCs are essentially spatially restricted chemo. You're just delivering high doses of cytotoxic right to the tumor cells. We've seen a lot of early data that the AstraZeneca drug called Sony-V, colloquially, is quite active, and this is a very large phase 1 trial highlighting the nice response rates for the antibody drug conjugate. And so this is moving, these are the toxicities which are chemo-like, cytopenias, GI toxicities, nausea, vomiting, etc. are Claudin, and then you have some typical chemo toxicities. So these drugs are not benign, but certainly are manageable in my own experience.
But better than zolbetuximab in terms of nausea and vomiting, or still a problem?
Periodically still a problem, but I think overall I've had more Zolbe than AZD experience, but perhaps a little bit less nausea. This is the frontline trial to see if we can bring these agents to the frontline, and it's stratified by PD-L1 status based on the labels. And here's my summary. I won't belabor reading it, so we have enough time because I know Yelena's got some good slides.
All right, so we're going to move on now, and we get to Yelena. When I saw that Horizon study, the first person I thought about was you. I was really curious what you thought about it, so I'm glad to have the opportunity to ask you.
Thanks for the invitation. So, of course, HER2 is my favorite topic, and it's amazing to be able to see that the work that we've done is really being built on and expanded. So, of course, the TOGA study led to the FDA approval of trastuzumab over a decade ago, 13 years ago now. And since then, all the other studies have failed until we went outside of dual HER2 blockade, for example, and started to combine it with anti-PD-1 because we know that PD-L1 overexpression is high and prevalent in HER2-positive disease. So this was the KEYNOTE-811 study, of course, that led to the FDA approval of pembrolizumab trastuzumab. This was done in a PD-L1 unselected population for HER2 positive IHC3+ or IHC2+ and FISH positive global study. Close to 700 patients were treated and randomized against placebo. So this was a double-blind placebo-controlled study. And of course, the long-term overall survival read out positive. So this regimen led to FDA approval based on initial response rate that you will see, but also subsequently demonstrated progression-free survival and overall survival. And so the benchmark for median OS in this disease is 20 months, which I want you to pay attention to this number, but also to the placebo group, which is, as you see here, is also quite good. But, again, the survival curves separate, and there's a sustained separation in the survival curves, which is great to see. And based on this, the FDA approved it and restricted it for PD-L1 CPS 1 or higher, similar to the HER2 negative space. Of course, progression-free survival is important in our disease. The hazard ratio is 0.71, and the median PFS we're expecting is approximately 10 months. And many patients do quite a bit better, especially those patients who achieve complete response or deep response. And what we do see is in the shape of the survival of the waterfall plot, the percent of patients with more than 80% tumor reduction, as you see here on the left in the green, is higher. We have a higher pathologic complete response rate, and this really translates well to long-term survival. So what is next, right? So Pembro-Traz has been the standard for many years now. We know it's well tolerated and is safe. In fact, probably my favorite memory about running this phase 3 was when the investigators and friends were telling me, Yelena, I really don't know what arm my patient was randomized to. It's really well tolerated. So, and we know that the subgroup of patients that may not benefit as much is PD-L1 low population. In fact, here the hazard ratio crosses 1, which raised some alarms. But again, CPS scoring is quite tricky, and the number of patients in that cohort were quite low. And as we are updating these numbers, the hazard ratio with each update are reducing. So what is a biparatopic antibody? So it's slightly different than bispecific antibodies in the sense that it hits 2 of the same epitope, just at different locations. And as you see here, it's kind of a funny design where one of the arms is shorter than the other, and it causes a certain cross-linking that induces CDC, complement immune response, ADCC, and phagocytosis, or ADCP, much more potently than trastuzumab. And I remember doing the phase 2 study in the United States, and I was struck by how deep also these responses were with Zani in combination with FOLFOX. But I was also struck by the amount of diarrhea that these patients were having, of course, in combination with 5-FU, with overlapping toxicity. I'm still traumatized about all these descriptions and pictures of diarrhea that the patients were sending. And we were all set. No joke.
Wow.
Yeah, but because it's in a clinical trial and the patients want to say, well, just in case it's helpful, let me say this. And they bring it with you. I'm like, well, thank you very much. It is very helpful. Right. So, but I was all set and excited to write, we helped write the phase 3. We were ready to start, but the FDA approved KEYNOTE-811 before, and so it kind of derailed the registration strategy in the United States. The Horizon GA, as a result, did not occur in patients in the United States because the comparator arm did not contain KEYNOTE-811. But nonetheless, so this was a Canadian company, Zymeworks initially, so Yelena Ilimova presented this data. She's a Canadian PI at ASCO GI, and we're very excited to see it because for the first time in a long time, there's another breakthrough in first-line HER2 space. And here, the combination of both Zani, which is, as we discussed, is biparatopic, with chemotherapy or the Zani with Tisli, which is another anti-PD-1 agent that's available, and chemo were compared to the TOGA regimen. So there was no KEYNOTE-811 comparison, which makes it a little tricky to look at the data, but not insurmountable. So let's go through it carefully. Here, once again, patients were enrolled for HER2-positive disease and irrespective of PD-L1 status, but the stratification factor, unlike KEYNOTE-811, where it was PD-1, here the HER2 status was the stratification factor with dual primary endpoints of PFS and OS. So bear with me because it's quite a few comparisons. So the first comparison is the PFS by blinded independent review of Zani, Tisli plus chemo. So the kitchen sink arm compared to Traz chemo, and as you see here, the PFS is 12.4 months, where in KEYNOTE-811 it was about 10 months, 10 plus some. With trastuzumab chemo, PFS is 8.1 months, which is already better, than we historically saw in the TOGA study. So the control arm did quite well here as well, and nonetheless, Zani plus Tisli clearly beat it. Hazard ratio is 0.63, which is really great to see. So next is the Zani plus chemo versus Traz plus chemo, and clearly Zani plus chemo is the winner. So we know that Zani is a better HER2 inhibitor, hands down, with almost more than 4 months prolongation in median PFS. Well, what about Zani Tisli for OS versus Traz? And that data is also looking promising and is positive. Hazard ratio is 0.72. And this is the money shot. The OS for the Zani plus Tisli is 26.4 months, which is quite remarkable. And the fact that these patients in a phase 3 setting are living this long is amazing. United States patients were not in the study, but nonetheless, there were Western patients from Canada and so forth. And the p-value is quite significant. So what we're seeing here is that our HER2 patients, even with Traz chemo arm, are living longer. We're taking better care of them, likely because we're giving them more second and third line therapies. In key pre-specified subgroups, the interesting point that there was benefit irrespective of PD-L1 status, so that will be a key improvement. And there were key improvement in OS occurred across major pre-specified subgroups. And so here, again, the TAP score is used, which is what we use with the Durva as well, but it's very similar to CPS. So primary endpoint of overall survival in the interim analysis did not meet the direct combination of Zani, trastuzumab, but it was trending, and we're hoping, here the hazard ratio crosses 1, but there will be updated data. And this will be published in New England Journal of Medicine soon, so you'll see the whole manuscript. The response rate are similar to what we saw with KEYNOTE-811. Really what's driving the benefit is really the long-term outcome as well. So I just want to talk about, and again, we talk a lot about grade 3 toxicities, but it's similar with Zolbi, but also with Zani. The grade 2 toxicities is what you really have to be paying attention to. The diarrhea is the main toxicity you have to be aware of. And again, compared to phase 2 to phase 3, there was a steep learning curve. The investigators are using prophylactic loperamide. The patient has to take it within the first week of starting therapy or at the beginning of therapy, and the diarrhea can peak in 1 to 2 weeks. But what my experience is similar to with Zolbi is patient compliance. It's very difficult for the patients to oscillate between constipation and diarrhea. And in fact, since the data has come out, there's compassionate use programs for Zani. So I've been using it again in the clinic, and even in my experience with phase 2 data, the compliance with anti-diarrheal agents is quite important, but poor with this regimen. And of course, the grade 3 toxicity here with Zani Tisli is approximately 16%. Treatment-related diarrhea is 24%. So it's important to see. So 43% grade 3 So I think the field is definitely evolving. It's great to see combination therapies still holding place in HER2. Most of us agree that using combination therapy will be important in HER2-positive disease, but selecting the right patients based on functional status and so forth will be key.
So let's just take a deep breath here for a second. I want to ask you, of course, the key question here, which is putting aside reimbursement. I mean, I'm curious whether you think Zani is going to get approved in this situation, but it already is approved in terms of biliary. What do you think is the optimal first-line therapy of a patient with HER2-positive disease, PD-1 positive, PD-1 negative? In general, what do you think is the best therapy?
In the fit young patients with large disease burden, I would use Horizon, the Zani combination. In a patient who's elderly, maybe borderline functional status, I would probably still use Keynote-811.
So I want to ask Sam the same question, but I take it one of your big issues here, I mean, it's interesting, I've asked other people, I remember we did biliary programs where people were going, oh, the diarrhea is not that bad. You know, Mamta, we've had a lot of history with anti-HER agents and diarrhea, neratinib, where we came up with dose escalation, preemptive low modal, even pertuzumab, you see a lot of diarrhea. But I take it that's the main hesitation you have?
In biliary cancers, they don't use FOLFOX with it. I think that's the big.
Oh, really? That's interesting. So, Sam, agree? Not everybody first line, just people in better condition?
Yeah, I mean, most people, I would say, I would lean towards the Horizon regimen. I mean, I think the diarrhea is something that can be improved upon. You know, they stopped the prophylaxis at 7 days in the trial, and in real clinical practice, you know, I don't anticipate I'm going to be arbitrarily stopping it at 7 days. In fact, we don't. We check in with the patient at 7 days and ask them, and then so I think we can improve upon it to make Zani more tolerable for more patients. But patients who have a true HER2 IHC 3+ and PD-L1 strongly positive, like they're going to do fantastic with 811 for the most part as well. So I feel I have many patients on the 811 regimen, 3-5 years out alive, particularly those with node-only disease. Those patients do great.
Sounds complicated to me. Mamta, any questions? This does not sound easy to figure out at all.
Yes. When we do the combinations for like Claudin and IO regimen, I feel like once they progress further, and if they're HER2 negative, we don't have treatments left other than just chemotherapy. What's your thoughts on it? Like, do you prefer to do all in together upfront, like if once we have those data as mature, or do you do sequential Claudin, PD-L1 based, IO? And
Sam, that's the most common question we're getting from the audience right now. So their CPS is positive, or the Claudin is positive. Right now, are you going to use both?
Yeah, so I do a fair amount, and I would say that it's always humbling to be reminded that even in phase 3 trials, like somewhere between 40 and 50% of people never get second-line therapy. So we sometimes really have to deploy, I think, our best combinations up front, particularly when people are symptomatic. But you're right, after FOLFOX and Zolbi or FOLFOX, Zolbi, and PD-1, it's mostly Taxol and ramucirumab unless we have a trial.
So let's talk a little bit about TDXD. Yelena, at the end of this day, we're going to hear Erica Hamilton talk about the first-line trial of TDXD in HER2-positive breast cancer, which is positive. Looks like TDXD is going to be part of first-line therapy of HER2-positive breast cancer. Where are we right now with HER2-positive gastric cancer?
TDXD is front and center in a second-line and third-line setting, as you heard earlier, and we'll review DGO4 data. This is a DGO3 trial, which we designed many years ago, and now finally resulting to look at TDXD-based combinations in first-line setting. Once I saw the Keynote-811 data, we knew that we needed to move more potent HER2 inhibition to first-line. And the way that I would think about it, it's, HER2 is a heterogeneous biomarker in gastric more so than breast, and we need bystander effect that TDXD offers to take care of the HER2 low or HER2 negative clones in the same sample. And also, it's a non-platinum containing chemotherapy, the way that I would do it. And irinotecan, of course, or topotekans are very active in gastric cancer. So this study showed feasibility and safety of combination of fluoropyrimidine It's the first study to show that in combination, so capecitabine plus T-DXd and anti-PD-1 therapy, in this case pembrolizumab. We also had a rilvegostomig arm in this study, which is the PD-1 TIGIT bispecific. You see here the waterfall plot looks amazing. We had essentially 100% disease control rate, and the data appears to be irrespective of PD-L1, but in PD-L1 high population, the benefit was even stronger. It was quite doable, the combination with capecitabine. We were able to deliver it. Of course, 50% grade 3 toxicity is, what we see in phase 3s with FOLFOX/nivo, for example, is 60%. So it's not bad. PFS is 12 months. And the question is, will it be enough to beat KEYNOTE-811 or even eventually Horizon? That's the big question. So right now, DESTINY-Gastric04 solidified the use of T-DXd in second-line setting. Of course, for us, it was a non-issue. It was a similar thing. We wrote DESTINY-Gastric04, and then the FDA approved T-DXd in second-line setting based on DESTINY-Gastric02. But the rest of the world did a confirmatory study. Thank you very much. And again, Taxol-Ram is officially dethroned in HER2-positive disease, where we see deeper and more durable responses with HER2-directed therapy. The 2-year OS rate is doubled, which is, again, to quote this, in metastatic second-line setting in gastric cancer is a game changer. Hazard ratio is 0.74. And because of this excitement is why we're taking this drug to early first-line setting, because we know that in gastric cancer, you have to use all your best aces up front because there's attrition. Some patients may never get to second and third line. So if you're waiting and saving those cards, you're going to do a disservice to some of our patients. So we need to go big early. Of course, the safety we know, and luckily the community of gastric doctors is here, but realistically, non-specialists mostly treat this disease, right? And so people are comfortable using T-DXd because of its pan-tumor approval, but also, of course, breast cancer approval. ILD risk is real, but doable, and with lower dose of T-DXd, which is used in the study, 5.4 mg per kg, in our DESTINY-Gastric03 with pembro combination was not an issue. And based on DESTINY-Gastric03, we now have two first-line phase 3 studies. DESTINY-Gastric05 used T-DXd in combination with pembro and fluoropyrimidine, and there's a CPS high and the CPS low cohort. And this is sort of the purest approach. And then, of course, Artemide used it in combination with PD-1 TIGIT bispecific, rilvegostomig, which we know the TIGIT story is quite sad and complex in this disease. So we don't know if there's going to be contribution of component. In the last minute, I wanted to tell you, but of course, solidify of what we're doing in perioperative space in HER2-positive disease. Well, Matterhorn, the anniversary of the plenary will be at ASCO this year. And so we need to continue to push the envelope for biomarker-selected population. We're doing a perioperative Claudin study and perioperative immune checkpoint blockade, dual immune checkpoint blockade study. But for HER2-positive disease, we're already doing a pembrolizumab, trastuzumab plus FLOT study. This was an investigator-initiated study that we started at MSK and with CAPOX, but once Matterhorn read out, we amended it to have FLOT. And here we're already seeing some promising responses, 83% clinical complete response rate. This regimen is doable and safe. But more importantly, what we did is doing more cycles neoadjuvantly instead of all cycles, 4 and 4, we're doing 6 neoadjuvantly. And the most innovative portion of this, I think, is the study enables organ preservation. So thanks for your attention. Happy to take any questions.
So just one point, and then we're going to take a break for lunch and come back and talk about, actually we have your colleague, Dr. Grounder, here talking about desmoid tumors, that I always love talking about. What an incredible story. But just, I'd like to once we get outside breast cancer, I'm always curious about how people deal with toxicity from T-DXd. Sam, the two big issues, and I'll be curious what Mamta's thoughts are about this. Acute GI toxicity, how are you managing that? How are you preventing it? And how are you screening for ILD? Will you ever re-challenge a patient who develops ILD?
Yeah, I think, one, I have migrated more and more to the 5.4 dosing, even though the original gastric approval was 6.4. And I think that does help mitigate some of the fatigue and cytopenias and some of the GI toxicity. It doesn't make a huge difference in the ILD risk, at least cross-comparing against the breast. We don't do any particular enhanced surveillance. We're getting the imaging assessments, every 3 months for patients, and we look at the CTs in detail with our radiologists. But if there's evidence and totally asymptomatic, then often I will continue if the patient is doing well. A few other clinical things that I've done over the years is every once in a while space the 3-week interval to a 4-week interval. And I have had a very good experience. Admittedly, we don't have a lot of data for that, but it does seem to give patients the extra time to recover. I find since the people do well, they stay on for a long time, and the cumulative fatigue can add up.
So, Mamta, any final thoughts? I just imagine a general medical oncologist, there's this module after module, which is like, wow, is how you deal with this. Any final thoughts or questions?
Thank you very much. It was a great presentation. I would like to remind all my FCS colleagues that we are also participants in clinical trials. We have a great trial right now going on, GI411, which is anti-HER2 based HLX22, and we have other trials as well. So please, when you see the patients, keep that in mind and try to enroll more patients.
What a great point.
Yeah.
All right, we're going to take a lunch break. Thanks so much to the faculty.